do. I'm just kidding.
Take your
This is
time,
part
Sarah.
3. Yeah. I think
Of
so.
5 total.
Yes. So we've already covered. This is our series to increase OMT use within the office, not just within our clinic, and then also in our regular office hours. So we've done. Tina did constipation. Karen did headaches, right? Dimitri's going to be doing shoulder, and then Mira's going to be doing COPD/asthma.
Sounds good.
Maybe.
Yes.
Maybe, we'll see. And my topic is low back pain, it was back pain. But since that's a very broad topic and can include a lot of things, I decided to focus on just low back pain and specifically lumbar. And that's me. You all know me. So just an overview. We're going to talk a little bit about epidemiology of low back pain, just a very, very brief anatomy review. Something that we thought was important to include was differential diagnoses and red flag symptoms and things that you don't want to miss, and including indications and contraindications. And then the bulk of this time I want to spend on treatment and come up with a few techniques that can be kind of your go-to for low back pain. And then at the end we'll just review some billing codes and things like that. So I looked on, there was 2 AAFP articles on low back pain, which I thought were pretty applicable to this topic, that had some interesting facts. So they say most primary care physicians can expect to see at least 1 patient with low back pain. I think we all know we see much more than that, but that's at least the minimum. And I thought this was interesting. So most patients with low back pain see primary care physicians the most, compared to other specialties in musculoskeletal fields like physical therapy and orthopedics and chiropractors. So we are the front lines of this problem, and so we should feel very comfortable in treating it. The economic impact, it has up to a $90 billion impact annually. If you think about all the like MRIs, imaging, x-rays, in addition to various treatment modalities, it can really add up and affect the cost of our healthcare system. Whereas OMT is a pretty reasonable technique to use that can avoid a lot of those costs. This was a worldwide effect, not just the United States. It says 23% of the population has low back pain, and up to 80% have a recurrence within 1 year. But I feel like that number is probably bigger within the United States, especially with the obesity epidemic and all that weight on the vertebral column. I definitely feel like that number is higher, but I didn't find a specific number for the US. And then I thought this was also interesting, increases in Medicare expenditures, which is like how we get a lot of our data. This article was from 2009, but it says epidural corticosteroid injections had a 629% increase. And opiate prescriptions had a 423% increase for low back pain. I'm sure that number, especially in opiates, have decreased over the years, but that is pretty profound. So brief review on anatomy. So this is the lumbar vertebral bodies, or vertebral column. And this is kind of a cross-section of it. And as we all know, there are intervertebral discs that can sometimes be bulging and have radicular symptoms. And then specifically for OMT, we focus on the spinous processes and then the transverse processes, and that's how we can tell if there's a dysfunction. And then there are a ton of muscles in this region of the low back. So I thought this was a good picture to kind of describe that. These are the muscles that we're specifically working on. So you have your paraspinal muscles. I think it was in med school, it was always like, I love spinach. So iliocostalis, longissimus, and spinalis. And then this doesn't show even like relatissimus dorsi, and then the serratus posterior inferior. So there's a lot going on, including your abdominal muscles as well. So when Mira and I were talking, we felt like it was important to just have a slide on low back differential diagnoses. I'm not going to read through all of these with you guys, but just the point of this is to think about, in your history, you want to get a very good history to think about what else could this be before kind of narrowing on musculoskeletal pain to lead to OMT. So you don't want to miss some of these things, like an aortic aneurysm or especially metastatic carcinoma. That's a contraindication to OMT. And then I wanted to put these at the bottom. They're specific MSK diagnoses, but you would not want to do OMT on if they have a vertebral compression fracture, or if they're having slippage of their vertebral bodies, or spondylolysis. So you always think of those in like the Scotty dog fracture, in like young athletes, gymnasts, people that are having a lot of compression on their vertebral spine.
Can I ask a question?
Yeah.
Or are we saving questions to the end?
No, it's okay.
To the end, if you don't mind.
I don't mind at all.
Red flag symptoms are something that we always ask in our office visit, and I try to kind of group them together. So the first in red are cauda equina type symptoms. So if you're having those, you definitely want to send them to the emergency room for an urgent MRI. The symptoms in blue, can everybody see this okay?
Mm-hmm.
I'm not going to read through every single one because I want to spend more time on the treatment aspect of it. But the symptoms in blue kind of alert you for, is there some sort of malignant process going on? And then the last are kind of a hodgepodge, but if they have any trauma in the area, you want to get some imaging first. If they have a lot of chronic steroid use, you want to make sure that they don't have any degeneration of their bone, or if they're IV drug abuse, or if they're just seeding septic emboli everywhere. So that wouldn't be good either. And Mira and I also talked about, I did just add this slide in. So on diagnosis, so we all know we've been doing this for many years since medical school, but just a quick refresher. So you want to start out with your standing static exam. Structural, thank you. Exam where you look and see if there's any asymmetries. You want to see the curvature of their spine, if there's increased lordosis in their lower back, like a lot of pregnant people have, and find those points, since that's one of the criteria for TART. And then for the examination sequence, this is really what we do when we're diagnosing anything osteopathically. So the same applies for the lumbar region. And then one point we wanted to make in particular is the seated and sitting flexion test, because that's how you will differentiate between a lumbosacral etiology or an innominate etiology, and that will dictate your treatment. So just a quick refresher, you do put your thumbs on the PSIS, and you stand behind the patient and have them bend forward, kind of touch their toes in between. And if one of your fingers goes up, that's the side that's affected for, it could be either lumbosacral or innominate. And then you do the seated flexion to confirm, and if there's this way, and if they're sitting down and your finger goes up, that is indicative of a innominate dysfunction. Okay, always get that mixed up. Innominate dysfunction. So then you would go down a different path. Okay, so our indications for performing any OMT treatment is our TART mnemonic, so tissue texture changes. And I also wanted to say that this is important for documentation purposes as well. So you need to document one of these in your physical exam in order to bill, and for good documentation purposes. So you need to document a somatic dysfunction. So for tissue texture changes, you could say like hypertonic paraspinal musculature. For asymmetry, you could comment on that structural set. What do we call it again?
Structural excess.
Structural.
Yeah. Or
exam.
like range of motion. I mean flexion extension.
Yeah.
Or
From the picture that I had on the other slide. And then restricted range of motion, say they can only flex like 15 degrees, that would be restricted. And then any tenderness to palpation, which is the only subjective TART finding. And anytime we're doing a procedure, we want to think about contraindications. So there's different contraindications to different types of OMT techniques. So you're going to have different contraindications for myofascial release compared to HVLA. So these are kind of just general ones that kind of apply to all of the techniques, but you just want to be aware of what technique you're doing. So relative, if they have very severe muscle strain where it's so acute you're not able to perform a technique, it's just too painful, you could think about doing an indirect technique for that. You could think about, like for instance, for the head we do the oculogyric
Gyrate reflex.
Reflex.
Right.
Using all my words today. So you could think about that, but sometimes it's just too soon to do any treatment. If they have osteoporosis, you want to be aware of that. Any severe illness, if they're in the ICU, you're probably not doing HVLA on that patient. This is important, hypermobile states. So if we all remember from med school, rheumatoid arthritis and Down syndrome both have instability in the atlantoaxial joint. So you want to be very careful with the neck and also other joints. And then any like herniated discs, you don't really want to exacerbate that. And then absolute would be any sort of fracture, dislocation, really severe joint instability, you don't really want to go near that. Any metastasis, you don't want to seed malignant cells in other places. And that same goes for any infection like osteomyelitis. Okay, so this is what I wanted to concentrate on. So for treatment for lumbar somatic dysfunctions, and I gave, the paper kind of gives, I think there's 6 techniques on there, starting from the beginning, about these. This is something that you can kind of keep in the back of your mind in the office. So always want to start with parasympathetic treatment, so address the entire nervous system, and I always start really any treatment with a suboccipital release. That's usually my go-to first treatment technique. And then especially for the lumbar, sacral rocking, which I took this from Tina's side, so thank you. So that will also address the lower nerves in the spine. So with that, and inhalation, you encourage sacral extension by pushing on the apex, and then exhalation would be on the base, and you kind of just rock back and forth as they breathe. Myofascial release, I think this is just a good starting point, kind of just going, not less aggressive, but just the most kind of basic and superficial to deeper structures, and that's how we really approach anything in OMT. So myofascial release, you can go indirect or direct, and you want to place your hands in like superior, inferior, right to left, and clockwise, and you want to stay consistent. Like if you're either going in all the E's or all the bind, and you would just hold it there until you have tissue texture changes. And you can kind of do that like really wherever. So the next thing, for low back pain, I use probably the most common techniques I use are soft tissue and muscle energy. So I think soft tissue is a great way to loosen up those muscles that we saw in the anatomy slide. I use this one the most commonly. We all learned it as like the cat crawl in medical school. And so basically you want to put extra emphasis on your thenar eminence. And so you're standing the opposite side of the back that you're treating, and you kind of use your body weight to use some pressure and just kind of walk up and down the paraspinal musculature. So that's the one I use the most common. We also use, I don't know if you guys remember from school, for pregnant patients, so patients that can't lay supine, they can go in the lateral recumbent position, and again, using your body weight, you want to protect yourself as well. Don't want to pull your own back out while you're doing this. So that could be a helpful technique to use. But this one I thought, I haven't used this, but I think I'm going to start because it provides a good fulcrum for you. So you stand again on the opposite side. All of these are on the opposite side of than the side of the patient that you're treating. And so he's pulling up on the ASIS and then pushing down with his hands. So I thought that could be like a good addition to the other classic treatments.
That one's a great one, but the patient's supine instead of prone. It's a lot more comfortable for a patient. It's but I use it a lot for soft tissue.
Okay, so they would be, and then you just pull up and push
Exactly.
down.
Exactly.
Okay. Counter strain is something that I didn't typically use, but I think I'm going to incorporate into my routine because it's so easy. And especially for the lumbar, if you just think about, it's the ASIS and then AIIS and then pubic symphysis. So if you just remember medial, lateral, inferior, pubic. But honestly, you're just gonna find where they have a tender point. So even if you don't remember any of this, that's fine. You're gonna find where they have a tender point, and then what I wanted to convey is that you don't need to remember this. If you just remember fold and hold, that's kind of the gist of it.
Exactly.
So, and you can see like this patient, so if you find a tender point in their pelvic region, you're gonna be flexing their legs, so that's kind of common sense. And then you're just going to kind of put it in a position where they don't feel pain anymore. So even if you don't remember all of this, that's fine. You just find it where they are not having pain. And then just some reminders is you want to keep your finger there the whole time and just check and hold it for about 90 seconds. And then at the end, have the patient just totally relax. And you don't want them to be doing any work when you lower their legs. So just remind the patient, like, I'm going to do all the work, and then lower them down, and then you press again at the end. But if you just remember fold and hold, I think you can just figure it out based off of your, based off of their pain. So the other thing that I love is for muscle energy and HVLA in the lumbar region, it's the same position. So it makes remembering things a lot easier, and also time-wise, like more efficient. So there's two that I'm going to show you. So this is the lateral recumbent, and then we'll move to the seated position. So in, okay, so this picture is this diagnosis, and then this one is the bottom, and I think, yeah, this one is that one as well.
And we can take some time to practice it. You don't have to go through the exact.
Okay. Okay.
Just so you.
Okay, perfect.
Times.
But okay, essentially, you can do muscle energy, which we all know how to do, and then if you want to do HVLA, you could just do it right there. So you don't have to have the patient reposition, and that can take some time. And just to show again that there's lateral recumbent, and then this I like this technique that I think we should practice. And then this is a seated position, which could also be probably easier for us in a lot of cases, especially if somebody's not coming in for a whole OMT session, like if they're just coming into a regular office session and have back pain, like I think we could do this pretty easy. And they talk about long lever and short lever, which we can practice, but essentially short is just more of a quick motion, whereas the long is more of like kind of pulling that way.
Only limited by if the patient's much larger than you, that's very hard to do.
Sure.
Seated.
I was thinking that would be.
That's true. Yeah.
Dr. Nicholas looks a lot bigger than that.
Yeah, that
patient.
is true. And then just to kind of close off is billing. So what we went over, this was just lumbar, but we did, if you would start out with parasympathetics, you would have be treating the sacral region and the head cranial region. So that would be 3 to 4 areas. And then just as a review, I know we've gone over this a lot of times, a DO attending has to be present in order to bill. And then if the patient is coming in just for a OMT session in the sense of like they were already diagnosed in a previous visit, you don't do a
Modifier.
ICD-10 code.
You don't do an E&M with the
E&M
mod.
code. And you don't do a 25 modifier, you just do a CPT code. But as opposed to say they're in the office and they're coming in, or not specifically for OMT clinic, and you're diagnosing them with they come in for low back pain, you're diagnosing them with a musculoskeletal dysfunction, then you would do the E&M code, a 25 modifier, and then a CPT code.